red is Yakima, and the one that's yellow over here on the right is Washington State. So those are, so look at Yakima, 18 to 19-year-olds, and it's open that county that I was telling you most Clarkston is, which is a bit of an anomaly, is also really high as well. So Franklin and Yakima are the ones that have the highest pregnancies. And you can see, especially for 18 to 19-year-olds, both 15 to 17-year-olds, I would have thought that would have been the case for Yakima.
I got your email.
So there's some real opportunities in these counties. So Yakima is where the 3 FQHCs are, and Franklin is where
I'll check when I get back to the office.
Yep, and you wonder, how many of those are intended or they're not.
Good morning, sir. Good morning.
Because they're from their graduated right away, intentionally, but some of them are probably going to community college or trying to do it.
Yeah, I'm very good friends with the OB nurse practitioner at GCACH. And she tells me, these women come in and they're young kids and they just don't see any opportunities for themselves. They say to themselves, why shouldn't I just do this? So we've got some cultural issues that we're trying to relate to race. Right. So those sorts of things are hard to turn around. So, it makes sense. This is why I'm so excited about it.
That's how I usually
So it's sort of, I don't want to say that it's in balance, but it's like, okay, you're in this position, you need to do this. You have to do this. And we're going to do it. Hopefully that doesn't sound too forceful. I think it's the only way you really make a change.
Yeah, I think it's also just about approaching it in a way that you're allowing young women to have a conversation how they're planning their life and when they want to become a parent in relation to that. And to be able to say, we have great options for you.
It would be great to sort of connect with some other things as well. And that's the conversation school, college, what can we do to help you fill out your application? I mean, some other things too. So you have a
the concept of wraparound, which is what I think that's
some people have done a lot of great stuff. I work for Tri-Cities Clinic. Sort of going through that experience, I can see lots of opportunities. We're going to be here in about 5 minutes.
Oh, great to meet you finally. My name is Ashley Fernandez. Yeah, and I certainly heard your name, but I don't know before I forget. Welcome.
Move over here.
Oh, awesome. Okay. And one of the times.
Oh, yeah. So when we get to that point, I'll just
Okay, so great. Yeah, because otherwise I don't.
yeah.
Yeah.
I'll be actually the whole time, so
401.
anything goes wrong. I'll be right there. We have a mic if you want to use it. Like I would say 50-50 on people that want to use it. Actually, if I project it, I would not. Yeah, I think that's it. Everything's really doing like director support. I'm watching the website. Her presentation on graphic. Pretty low.
If you get a chance,
Yeah. Yeah, and we're recording it too.
I find that
I can give you the. Yeah. I mean, I know I won't catch everyone, but. Rather you. Yeah. I think it was a good time going back. Replying to Philip.
no, I know, but you like,
I just leave it highlighted. That way. Yeah.
Of course.
Yeah.
You're Megan, right?
I'm Megan.
You're Megan. Okay, did you get mine?
I did. Yeah, I replied to you.
Are you good? I was driving. I have another copy. How much
down the right path.
Megan? Good morning. We got people on the line. You know how many?
Yeah, we got people on the line.
No, I think we're good started. I don't know what the RCC count is, but it's after 9, so we can go.
Good morning, everyone. Welcome to the Leadership Council of the Greater Milwaukee GCACH for the month of March. I'm Patrick Jones, the person who stood before you, hopefully made not too big a fool of himself over the last few months. We might ask you to make fools of yourselves this morning, though, introduce yourselves, because I want to hear what you're doing for St. Patty's Day. I'm in Spokane, Eastern Washington University, and the town kind of goes crazy in Spokane, and so you don't need to let us know that you're going crazy, but tell us what you might be doing on this Saturday, which is the first time we've seen St. Patty's Day on a Saturday, obviously, for a few years. We've got a pretty full agenda. We've got 2 presentations. One from Chelsea from the west side, and the other from our own Brian Sandoval from the Yakima. So we want to get started as soon as possible to allow lots of conversation like we did last time. So I'm going to start. We have kind of a back row syndrome here. I'm going to start with the back row people first, and if you just let everybody know in rather loud voice your name, your organization, and answer to if you have any plans for St. Patty's Day this Saturday. So I'll start with you.
I'm the executive director of the Community Schools of Franklin, and I'm not sure. I'm interested to hear what everybody else is getting, the other 2 ideas.
Okay, and agnostic. All right.
Sean Fidelity, been hanging out this year. Yard work and
That's good.
Chad Marmack with Ben Franklin Health District, and I'll probably be working on my tiny house.
Okay.
Kurt Woods and Ben Franklin Community Health Alliance.
And I'm probably gonna be doing some of the work I didn't do this week.
Miguel Messina, Vice President, Social Security Stores and Co-current Stores for Comprehensive Healthcare. I don't have any plans for that.
No plans, okay. No green.
A little bit, Franklin Health District, I'm hosting Shadle Park High School golf tournament.
And continuing on,
Ashley Nelson, care coordinator, Selena Healthcare, we're moving, so I'll be packing.
oh boy, okay. That's not too fun.
I got it just in time. Running for office with committee health in Washington.
And, any plans for this Saturday on St. Patrick's Day?
No particular plans.
Okay, so second row, starting with Carla.
Carla Prophet, Franklin Health District, and my youngest has been 48. It's always birthday back then.
Okay. Patrick, I hope.
Good morning, I'm Sherry Snow White of the Bear Group, and we are going to wear funny hats, just like one star, please read here.
Okay, Dr. Person.
Amy Person, at Franklin Health District. I'm gonna miss not being in Milwaukee.
That's true. I just want to live close to their desk.
Mandy Olson from Kentucky Valley Healthcare in Elmsford, Washington, and I'm going to a Thunderbird game. I'm sure there'll be beer drinks.
Martin Lamb, Columbia County Public Health. It was much optimism, I'll be watching the Zag.
Oh, yeah. I like that one. Okay.
Good morning, my name is Denise Fregoso, Molina Healthcare, and I will be working.
You'll be working.
Yeah, you bet, yeah.
Okay.
Colby Seiler, I'm the second artist, and I'll be away from crowds up at the South.
Okay. And moving over here.
Morning, Michelle Mann from Columbia Basin College, I'm the director of work training here. I'm gonna be cleaning up my garage, so if anybody wants to join me, I will.
I don't hear too much partying going on so far, so let's see what the second half
I'll bring
brings.
the beer if anybody wants to have it.
Wow, okay. Okay.
Brian Senval, Yakima Valley Farm Worker Clinic. I'm just gonna slow down and not travel.
That's good. Okay, and Sue?
Sue Jenner, CAMH Medical Center. Green beer will probably be involved.
There you go. First time there's green beer, I was waiting for that. Waiting to hear that. Becky?
My name is Becky Gross, and I'm the director for existing care services. And actually, I do have plans. I've had plans for this for 3 years. We're going to, with a group of about 10 friends, to the Big Minimums Resort in Troutdale. I'm Sarah Foster from Mercury at Sunnyside Hospital, and I'll be removing wallpaper.
Okay. Yeah, if you just introduce yourself, let us know what you're doing on St. Patrick's Day, if there's anything special.
I am Irish. I'm Susan Campbell, and I teach in the nursing program at CBC. And I'll be planting green peas in the garden today.
All right. A little bit of green.
Hi, I'm Barbara Lee, but my real name is Barbara Ann Catherine Kelly.
Oh, yeah.
I'm from Chicago, so I understand phrase, green beer. So, this year, I've been invited to celebrate with one of my dear friends. It's her 60th Jubilee to be a sister of St. Joseph of Carondelet. So, it'll be Saturday.
Nice. So, your name?
I'm John Mondell from the Richland School District, and I have plans to celebrate with my family, drinking some Guinness and fish and chips.
All right, all right.
There's probably the Irish stuff.
There's some Irish in you. Okay. So, now your name?
Matthew Gimple, with Lutheran Community Services,
Okay.
and I'll be going to Spokane to build furniture in a friend's office that they're in now.
Yeah, don't forget O'Doherty's downtown. It's
Yes,
a
it's
good
close
place
by.
to be. Okay.
I'm Ronnie Bassford, and I'm Lutheran Community Services. I'm going to be wearing in honor of my Protestant Irish.
A North Irish woman. Okay, so one of our featured speakers, Chelsea, is it Walliser?
Yeah.
Okay.
Chelsea Walter for St. Patrick's Day. I'm taking my mom to get new glasses at her optometrist. Plans, but maybe we'll wear green.
Wear some green. Okay, and over here, please.
Michelle Sullivan with Yakima Neighborhood Health Services, and we are doing corned beef and cabbage and soda bread.
All right, first corned beef and cabbage effort today. Yes.
Jocelyn Pedrosa, Yakima Neighborhood Health Services, walking the dog.
Okay.
Like to have different Yakima Neighborhood Health, and no plans yet.
No plans yet. Okay, you got a couple of days. Ruben?
Ruben Peralta, Greater Columbia ACH, and we're probably taking the children to see Stand and Deliver at Pasco High.
Okay. Mom?
Ashley Fernandez, Greater Columbia ACH. I'll be wearing green. My mom would always pinch me if I wasn't wearing green on St. Patrick's Day. My cousin's birthday is on St. Patrick's Day, so we'll be celebrating that. I will get to go to Ireland for this year, so I'll be looking for it.
All right, a little bit of Irish there. And Carol Moser, I don't know if it's Norwegian, German, any Irish?
No Irish. But we will be celebrating St. Patrick's Day in Austin, Texas this year. I leave tomorrow. We're going to go to Austin and celebrate with my son and my daughter. And unfortunately, we found out that this is one of the busiest weeks of the year in Austin with all of the South by Southwest festivals. So we'll be joining thousands of other people on the streets on St. Patrick's Day.
Wow. Maybe some green beer.
Yeah, it's going to be the party here. Kylie Spence, Greater Columbia ACH, which is probably just going to be doing some exciting yard work.
All right, and Mr. West?
West Lucky, Greater Columbia ACH,
Oh, come on. Yeah, and Megan?
Megan Summer, Greater Columbia ACH, and we're going back to Spokane this weekend to celebrate my father-in-law's birthday.
Okay, nothing green. So we have, Megan, 8 people on the line?
I think
Could those of you on the line just introduce yourselves, and if you would like to tell the group what you're doing this Saturday, that would be nice too. You don't have to.
Hi, this is Sandy Carollo. I'm with Washington State University College of Nursing, and I have no major plans for this Saturday.
All right, Sandy. Thank you.
Good morning. This is Mark Wakai. I'm with Providence, and I'm actually going to be taking off Saturday morning for a mission trip in Guatemala.
Oh, wow. Okay. Well, travel well, Mark.
Thank you.
Next.
Hi, this is Murray Thompson. I'm with our Cora Foundation, and if the weather cooperates, I hope to get a nice hike in on Saturday.
That sounds like fun. Good. Okay. There's a couple more of you.
Yeah, this is Bill Dunwoody from Catholic Clinic. If the weather cooperates, I'll be doing some spring cleanup.
Okay, no green beer there. All right.
No, after.
After, okay.
This is Heidi Bear, too. I'm from the Center for Community Health and Evaluation, and hopefully I'm doing something outside on Saturday.
Yeah, good for you. Oh, could you repeat the name?
Yeah, this is Heidi Bear, too.
Heidi.
Oh, thank you.
Okay, thank you, Heidi. Okay, a couple more, and then we'll get started here.
This is Gwen Cox from Qualis Health, and not sure what I'll be doing, but it involves green beer.
All right. Okay. A little bit of Irish in you. Anybody else?
This is Corey Blythe. This is Corey Blythe with Aging and Long-Term Care, and I will be spending some time with a high school classmate.
That sounds like fun. Okay. Is that it? Have we got everybody? Pardon me? Berta, are you there?
Hi, yes, this is Berta. What am I doing this weekend? Is that the question? Sorry, I joined in a little late.
Well, first of all, who are you with, Berta, for those of you who don't know? And second of all, what are you doing to celebrate St. Patrick's Day?
Okay, so I am from Virginia Mason Memorial in Yakima, and I am probably going to be putting some green coloring in my son's milk and anything else he needs me to do for St. Patrick's Day.
Okay, good. I like to hear some of that.
And then Larry Thompson, are you there?
I am. I already introduced myself, though.
Oh, okay, sorry. So have we covered everybody? Well, I don't think anybody is introducing himself or herself, so we'll just get started. So as you see in your agenda, we always start with. Oh, we're going to put you on the spot, sir. That was Carol.
Thank you, Carol.
You're welcome, Gary.
Gary, this is the Inspector of Child Healthcare. What was the question about?
What are you doing on St. Patrick's Day?
Tomorrow, right?
Saturday.
Oh, Saturday, sorry about that. Be in Libby, Montana, visiting my son.
Oh, okay. Lots of green trees there. All right, so we'll have a director's report, and then we'll jump right into our program, and should have time for questions within a half hour, and then we'll have Dr. Brian Sandoval, right here, our own, give us his experience in Yakima with behavioral health integration. So, Carol, your show.
Actually, as we experience transformation and we're continuing to evolve in staff, we're now just kind of at the GCACH report, because we have staff members that are now contributing to all the articles. So I will just cover a few, and then I think Wes has a report to give. But I had to reflect, I was getting ready for this meeting, that a year ago, we were just preparing to move from the Franklin Health Department to CAC. We had just hired Wes Lucky. It was me and Ashleen at 1.5 FTE. And since that time, we have gone through a major transformation as an organization. So we moved locations. I became a full-time director. We went from 5 priority work groups to 8 project teams. We went through 2 certification processes. We met as project teams. We applied with our project application. And here we are today with 6 full-time staff members, 2 of which have come on just recently, with Ruben being the latest hire, and Sam Riddell within the past 3 weeks. So we are transforming full steam ahead, and you will get an opportunity to see how we have transformed our website from Megan later on in the agenda. So actually, last month, if you were here, now I'm going to go off the GCACH report. Last month, if you were here, you heard Sam Riddell talk about practice transformation. And I think that this is the new paradigm that the staff is operating under now. We understand how important it is to practices to be a patient-centered medical home. Some of you already are, Yakima Valley Health Services, Yakima Valley Farm Workers, Yakima Neighborhood Health, sorry. And that really sets us up to have a successful implementation plan. So we're really going to be looking a lot about transformation and how, as organizations, we can play in. So I'm not going to read all of this, but I guess that the main message here is that we are going under our own transformation, looking at our project areas in kind of a new light. And in that, Sam Riddell will be leading the charge and actually hiring 2 more practice transformation navigators. So we're still adding staff so that we will have the capability of going out into the community and working with organizations that, you know, are really interested in becoming patient-centered medical homes and really elevating their local practice. To that end, the board approved last month the formation of a practice transformation work group. We had originally called this the strategic planning work group. That's how it was characterized in the project application, the project plan application. But we realized after meeting with our consultants that what we're really doing is practice transformation. So that's what we're calling the work group. And these will be our clinical champions in our major provider organizations that will help instruct us on how, you know, to inspire providers to adopt these change concepts and reconsider how the organization interacts with its patients. And basically just helping us get into those practices and those clinics to become the spokespersons for change. we've been working with the Yakima tribe on creating a dental health aid therapy program. And this actually, even though this wasn't a project plan application, it was born out of the oral health or the dental access team. And so we had the opportunity of presenting in front of the tribal council. And this is a pretty big deal to be invited to speak in front of the tribal council. And they were very gracious to those of us that went before them. We had Christina Peters, who's from the IHS, Indian Health Services Board from Portland, and she talked very eloquently about the possibility of having a GCACH on site at the reservation. And she talked about all of the different advantages of having dental health aid therapies. And because the state of Washington has kind of restricted dental therapy or dental hygienists, and they're not working at the top of their licenses, this is an opportunity for dental health therapists to work on the reservation and really improve the access for the tribal members. But beyond that, you know, it's a path towards job creation, and so that's one of the things that we're really excited about this whole program, is that if Greater Columbia can help support this pathway to employment, I think it's just a great model to follow in other areas. The next thing is the website transformation. Megan's going to take us through that, and then I'm going to let Wes talk a little bit about what we're doing in terms of reporting and IT transformation.
So Wes, you want to follow up?
Oh, sorry, got the word mixed up. So a lot of the work that we'll be doing will have a tie into information technology, health information technology. So we've been looking at some prospective software platforms to carry out our work. One of the most important functions that we'll be doing is collecting information from providers around their pay for performance and pay for reporting metrics. In demonstrations years 3 through 5, which is next year through 2021, we will be completely dependent on achievement of those metrics in relationship to our ability to route money out to our participating providers. So one of the programs that we looked at, this is just a real brief update, one of the programs that we looked at is called LifeQI. This is one that's being used by Pierce County ACH and perhaps some other ones. It's a very appealing tool in terms of its simple interface, easy to use technology. It allows us to do statistical process control charts, which are run charts with error bars. It has some program and project management capabilities. It's really a nice tool. It also has PDCA cycles built into it as well. So we had a demonstration of that. We'll also be getting a demonstration from another software package that's called CSI that a few ACHs, particularly Olympic, has bought into. And we'll be comparing those two packages together. There may be some additional software packages that we also look at, but for right now, that's our status with that. Does anybody have any questions about it? Okay.
Okay, so now are you going to give us a demo, Megan?
Yeah.
There's a lot of ways to look at our new website, so take it away, Megan.
I'm going to try out the mic since I'm going to have to kind of have my back turned.
Need help with the mic?
Yeah.
No? Okay.
So this is the homepage. We started this project back in November, and we went through the RFP process. And the company we went with was SiteWorks, that some of you may know. And this just launched, is it just Monday? God, it feels like forever ago. But we've been really happy with it so far. So I'm just going to do a quick overview of the site and kind of show you where everything is now. We pulled over all of our old content from our old website. So everything should be here, but I'll just preface this with, if you guys notice anything, if you have any questions where things are, or if you have suggestions on other resources or things that should be on our website, please just shoot me an email and we'll get it up. It's super easy to put up, so just let me know. So this top, this is our nav bar up top, but we'll start with just page by page. This is our spotlight. So this is just a running slideshow that kind of, right now it just links to some of our most popular pages that people are going to want to go to. But we can change these out for whatever we want, and they link to specific pages on the website, or they can link to different articles or different resources, which is really nice. We have a news section now too. So these are just, some of these are off-site. You know, if we get picked up in a local newspaper in an article, they'll go here. I'm also going to be adding some of the short articles that Carol has been including in her director's report, and now all staff are adding in that GCACH report. And if we click on one, it shows the details. So this one was actually a news article offsite. So this, if we click, it takes us to the actual article offsite, which is great. And then if you go to more news below, this just lists everything with including our featured and then our archive stories. So a lot of these are really old, and that's why, and those were all pulled from our old website. Below that, you'll see this section a lot across like the committee pages, leadership council, board, any of these groups that are meeting regularly. I have them put in this upcoming events section. So it shows, you know, the next 3 events, plus you can see the full calendar, and then you'll see this to sign up for updates. So if you subscribe to this, it sends you a weekly email with any new meetings that have been added, so you won't miss anything, which is really nice. If we click on today's, for example, so this is the event details. So this kind of gives you, you know, time, date, place. This is the virtual call-in information. And then if we go documents, this is where I'll be putting the meeting materials from now on. And then once we finish up the meeting, like today, we're having a couple presentations, and sometimes we don't get those until the day of, and we don't add those until usually the day after a meeting. So I'll add those to the packet section of the resources, which you guys will see in a second. But this will have everything you'll need for the day of coming into the meeting. And below this is our global footer that's everywhere. Just our basic things in case you missed anything. And then if you hit this button, this signs you up for a newsletter. So that's on every page that you go to on the website. I don't think we have a site map on here, no. And it is accessibility friendly. And it was actually really challenging to design around those standards, but it's really nice that everything is up to code now on that. Our old site wasn't, and a lot of sites have been, they're cracking down a bit more and more, so it was really nice that we were able to move forward with a new site where we knew that that would be taken care of. So we're back on the home page. These are some links, just in case you missed anything. If you feel like we need to add other links to things that you're going to be visiting regularly, please let me know. It's really easy to add other links here. If we go to About Us really quickly, these are kind of, this is like all about our main committees, Leadership Council, Board, all the groups that are meeting regularly, how to get involved in those groups. So this is a map of our region and the counties. This kind of just speaks a little bit about us. This is our staff. If you click on someone, and this is throughout the site, if we have pictures, they'll be up here, contact information, pretty straightforward.
You need to tell me the new domain.
Yes, and we also have our new domain, GCACH.org. If you go to the old domain, it'll still redirect you here, but it's nice to know that it's a lot shorter now. And our emails are shortened now as well. So like mine is mcomer@gcach.org. If you send an email to our old email, it'll still come through, it still forwards, but you just won't have to type as many letters now. And then we have some frequently asked questions below. They just expand if you click on them. And then, so for example, if we click on committees, this will show all of our active committees right here. And if you click on one of these committees, you know, we have our charter link up above. It talks a little bit about the committee members. As I said, if people have pictures, then it goes with their people detail. And then we see their next upcoming meetings, their next 3 meetings that are coming up. And then any resources that they have. So this is where like committee minutes or agendas can go if the committee wants them listed on the website. If we go to the calendar to look at the full calendar, this is just way more built out than our last one. We were relying on Google Calendar before this, but this is now in our website. If you click up here, this is that sign up for an event. Don't miss it. So that's in several different places. You can print too, should you want to do that. These ones that are grayed out, that just means they're an all-day event. And if there's anything, any community events, anything for your organization that you want to list, just send it our way and we can add it to our calendar really easily. Just send any details that you want listed with it, and we'll make sure that it goes in the event detail. And then probably the biggest page, this was huge, and this took the most time for me to bring over all these resources. But these are all of our minutes, director's reports, meeting packets, any presentations, just anything like that. So, for example, if we go to Leadership Council resources, and we go to minutes, we see that the last months are just right on top. So you can click that and it would open up in a new tab. These are all PDFs now too, which is nice. So we have just tons and tons of stuff up here. External resources are more like presentations. If we had an outside person come in and give us a presentation, or if they've sent us external resources that GCACH didn't put together, that's where these things are listed. GCACH resources are things that we've actually put together, or you know, our staff has made a presentation, stuff like that. So that's kind of an overview of where all those resources live now. And then the last page that I'll hit is just contact. So this just shows where we are, pretty standard contact page, and then all of our staff's contact information. So if you click any of their emails, it'll just hyperlink and you can email us right away. So that's kind of a quick overview. I know it was a lot to jam pack in. I just want to make sure we have enough time for our presenters. Any quick questions? Yeah, Ronnie? So I understand that GCACH is going to have some kind of training thing. Where is the training? Yeah. Like events? Would it be under the event? Yeah, so any events that we have would be on our calendar. Yeah. I mean, any meetings that are open to the public that we are doing, they'll be on our calendar. Anyone else?
I just want to acknowledge that this is Megan's last Leadership Council meeting today. There's a card back there and some flowers. I hope that you sign it. Megan has been a tremendous asset, and she helped us rebrand. And it's really good. Please join me in thanking Megan for all of her service to Greater Columbia.
Thank you all so much. It's been really great to work with Greater Columbia. So it's been a lot of fun, and I'm happy to help with the website. I hope that you guys use it a lot more, and that it's more friendly for you guys to navigate around and get to our resources. And as I said, if you have any questions or suggestions, just shoot them my way.
Megan, you'll be at your desk for a few more days.
Yeah, I am here through the end of March. So your next meeting will be with Lauren, my replacement, but she's super great. So and she'll have me on speed dial, I'm sure. So everything will be great. She's going to be really awesome, and you guys will really love her. So.
Thank you, Megan. As one who does a lot of websites, I just want to say this is a very, very user-friendly and well-designed website. So I appreciate that.
Thanks.
So, Carla, would you like to introduce our first speaker?
I'll come down here so I'm close to the phone. So, good morning, everybody. I'm Carla Prock from Benton Franklin Health District, and I was a co-facilitator for our reproductive and maternal child health project team last year. So what I wanted to do is remind you that the original project proposal that the RMCH team presented was twofold. The first contained some evidence-based home visiting opportunities for our region,
And the second part was our hope to decrease unintended pregnancies by providing provider education for LARC, which is long-acting reversible contraception, using the one key question approach in a wide variety of settings. So since the Reproductive and Maternal Child Health Project is no longer a focus project, we did agree that we needed to ensure that this population continued to be addressed on the remaining project areas that we would be doing here in the region. So how are we going to do this? One of the ways that I want to encourage you all to keep in mind as we continue to move forward with our primary projects is to listen to some transformation talks that are presented at least monthly by the Healthcare Authority in cooperation with Department of Health. And one I'd like to highlight, if I can, is the one that was done January 25th, which I was a part of, but it was called Building the Foundations for Lifelong Health, in which local public health experts from the Community Health Leadership Committee for Washington State Association of Local Public Health Officials, that's a big term, described how Medicaid transformation projects can positively impact reproductive and maternal child well-being and help build the foundations for lifelong health. We discussed how the life course approach and using that approach could apply to the opioid project, chronic disease, and physical and behavioral health project integration. So there were focus areas in all three of those areas with concrete suggestions on how you could make sure to include this population in that group. So those are things that you can do now to continue to move forward with the project planning. And one thing that you may notice if you listen to that is that the one key question approach is really highlighted throughout the transformation talk as a way to incorporate reproductive health issues into each of the remaining project areas. So Chelsea Walliser, our presenter today, is going to highlight how this approach can also be seamlessly incorporated into all primary care and urgent care settings by addressing pregnancy planning and the barriers to the long-acting reversible contraception access at this point in time. We know that clients are less likely to follow any recommended treatment protocol if they have to return to a clinic. That's the whole goal of bidirectional integration, right? And so Upstream can help us find solutions for this issue to reduce unintended pregnancies and provide lasting impacts to the health in our community. So please welcome Chelsea.
Very quick question, how do I access that presentation?
So I've sent the link to Carol and Wes, and I know that it's been shared a little bit, so hopefully we can get that sent back out.
We can put it on our website too, the information.
Fantastic. I can send it out again too if it's been.
Yeah, no problem.
Thank you, Carla. Good morning. Thanks for having me today. Thank you, Carla, and thanks to Carol and Wes for inviting me to join your meeting. I'm Chelsea Walliser. I'm the Executive Director of Upstream in Washington State. We are a nonprofit organization that works with health centers to help reduce the barriers that women face to getting the full range of contraceptive methods in a single visit, regardless of where they're seeking care, whether that's a family planning clinic, in a primary care visit, or even in a hospital system. We are working in partnership in Washington State with the State Department of Health, with the Healthcare Authority, and with ACH organizations across the state to bring our program to clinics in Washington State who are interested in working to improve access to contraception. We do this work foundationally because we have an opportunity gap in the United States and in many parts of Washington State. Children who are born into poverty in the United States are more likely to stay there as adults than they're more affluent peers. The reason this happens is because there's a full range of contraceptive methods, and some of them are more effective than others. The cheaper ones that are easier to get access to are less effective. The pill, the patch, the shot, condoms, things that require the user to do everything right all the time, every day, or once every 30 days. There's a range of other methods that are considered most effective by the CDC, which are the methods that Carla referred to, known as LARC, or long-acting reversible contraception, which is the subdermal implant that you might have heard of, called Nexplanon, and then the IUD, which there's a range of different IUD methods. So the fact that LARC is a little bit more complicated and more expensive means that typically lower income people have less access to this. It's more challenging to get because of multiple appointments, it costs more money, and that means that unplanned pregnancy tends to be concentrated among lower income families. And so our goal is to help improve the access to the full range of methods
for everybody in Washington State, regardless where you're getting health care and how much money you have to pay towards your health care. So even in Washington State, we have surprising challenges around unintended pregnancy. The national rate of unintended pregnancy is about 45%. We're doing much better than that, and a lot of good work has been done. So in Washington, about 35% of births are unintended. That doesn't include the abortion rate, so when you include that, we're definitely well over 40% of all pregnancies being unintended. And we're a state that has a great policy environment for reproductive choice, right? We have been a leader for decades in expanding access, whether that's at the ballot box or it's through our Medicaid expansion. We really try to make healthcare available to women and family planning available to everyone. But what these numbers say to me is that we still have a challenge with translating that policy environment and the ability to offer family planning to a clinic level in many cases. So what does Upstream do? As I said before, we're a nonprofit organization, and we work to help primary care organizations integrate family planning into the whole person approach that you are all taking as part of your practice transformation. So we help individual systems and clinics essentially implement a quality improvement program to address some of the barriers that women and that clinics commonly face in accessing contraception. So for those of you that are providers, what are some of the challenges that you see on a day-to-day basis in women getting access to contraception or to those most effective methods? Does anybody have experience with that? Providers or advocates? Mm-hmm.
So transportation.
Transportation is a huge barrier. Mm-hmm.
So having the method that the client wants to use available.
Yeah, having the method available in the clinic. Any other challenges?
Sometimes privacy concerns, especially for younger populations.
Privacy concerns, definitely. Yeah, especially if you're talking about billing insurance or if you have a parent in the exam room. Any other barriers from either a clinical or a business perspective? Mm-hmm. Can you say more about that?
So, particularly, there's certain cultures that
mm-hmm.
So we see that in our clinic.
Mm-hmm. Mm-hmm.
So having that discussion.
Yep. Yeah. So these are all really common barriers. A lot of them are logistical, financial, and personal around values and philosophy. So we work with clinics to help address all of those different barriers to try to get to the best practice around contraception access in a primary care setting. So what does that look like? What does the goal look like? So what that looks like is the entire staff, the entire care team is part of the approach and the conversation around contraception. So as a clinician, you have very limited time with your patients. So trying to have a more robust conversation about family planning and contraception, probably not realistic. But what we do is we help train the entire care team so that we can achieve task shifting to the nursing staff, to medical assistants, to help those staff members work to the top of their license, and so that women can have a more comprehensive conversation and a more in-depth conversation when they're there for the visit without taking too much of the clinician's time or adding too much more to what's being asked of them in the visit. We also help clinics deal with issues around workflow. So being able to fit contraception into your schedule, being able to have a room that's available if a woman is seeking a form of contraception that requires a procedure like the implant or the IUD. We work with you to integrate pregnancy intention into health screening and into the electronic medical record system. So what Carla mentioned around the one key question is a real new and developing best practice around how do you provide patient-centered counseling around contraception. And that question is, do you plan to become pregnant or do you want to become pregnant in the next year? And the change is asking women about their goals and their intentions versus asking them, are you on birth control? Do you need birth control? Which can be kind of a negative or a judgmental question or conversation, getting to some of the cultural or values issues. So asking, do you plan to become pregnant in the next year, is a way to open up a conversation that starts with the medical assistant or nursing staff and continues through when the provider comes into the picture. For women to say, you know, I do want to become pregnant again, but I just had a baby, and I really don't want to become pregnant again for 2 or 3 more years. And then the provider can have a more in-depth conversation with her about the full range of methods around, here's the methods that are most effective, here's how long they last, and here's how you can get access to them. Oh, and we can do this today at your visit if you're interested. Contrast this to what happens frequently now, which is a lot of women who are on a less effective method, such as the pill, get asked the question, are you on birth control? How's it working for you? Well, I'm not pregnant now, so I guess it's working. But it's a less effective method that is rife with human error, and it's harder for women to adhere to that than obviously something that's much more set it and forget it, if you will, than an implant or an IUD. So having the conversation in this way, really being focused on patient-centered counseling, allows for that conversation to take place where the patient's really thinking about what are her goals and what are the options for her, what's going to be most effective for her in achieving her goals. So we work with clinics and systems for a time-limited period of time. We know everyone's busy, so we work with you to design a quality improvement program to implement help that's tailored to your system, and we typically would work in partnership for about 6 to 12 months. We provide training, the technical assistance, workflow redesign, and help with billing, coding, and stocking for free. We also help educate patients about methods of birth control and the accessibility of all of the most effective forms in your clinic through a public engagement campaign to drive more women into primary care, not only to seek contraception, but for a wide range of health needs, but contraception is what gets them through the door in our marketing campaign. So all of the components of our quality improvement plan are grounded in studies that have been done around what's the best way to get women access to the most effective forms of contraception. You may be familiar with the program in Colorado that provided long-acting reversible contraception to women. Upstream was really inspired by a study called the Choice Project in St. Louis from 2007 to 2011 that asked the question, what would happen if we made contraception available to every woman in St. Louis for free in a single visit? So they saw dramatic uptake in most effective methods. They saw dramatic decreases in teen pregnancy and in abortion rates. And most importantly, they saw increased patient satisfaction. So women felt like they were being empowered to make an informed decision about their reproductive health, and they also felt like they got a better product at the end of the day that was going to work better for their lives. So Upstream was really inspired by the Choice Project because it brought together all of the best practices about how to improve contraception access in a primary care setting. Training for staff, integrating pregnancy intention screening, and addressing the technical and financial issues that health centers face in being able to actually provide birth control in a single visit. Since then, we've worked with health centers in 5 different states, and we started a statewide initiative in Delaware 2 years ago as our first program to see what will this look like on a statewide basis. Delaware is obviously a small state, so there's a lot of pilot projects that happen in the state of Delaware because you can reach the entire state and test things much more easily than a state of our size here in Washington state. But in Delaware in the last 2 years, we have worked with 90% of health sites across the state. So that's all types of clinics, whether major hospital systems, Planned Parenthood, or federally qualified health centers, and have trained nearly 2,000 staff members, both support staff and clinicians. And we've already started to see some results in Delaware around more women having access to the full range of methods and feeling really happy with the choices that they were able to make. So I just wanted to pause and show a video that's a case study of a federally qualified health center that we worked with in Massachusetts. This was one of the first clinics that we worked with. And it's really from the perspective of the providers and clinicians, what it was like to work with Upstream.
We're a community health center, and so our business case is always mission-driven. Our mission as a community health center is to provide high-quality care for everyone, regardless of their ability to pay. But we're always, I think, aware when we work with women in the childbearing age and women and children that sometimes people have unintended pregnancies, and that can certainly complicate people's lives.
We know in the United States that around half of all pregnancies are unplanned. And at our community health center, I want to make sure people know how often particular methods of birth control are letting people down and which other methods might be more effective. We didn't have any other organization that was offering to come in and train our entire health center and then provide ongoing support. Upstream came in. They trained every staff member, from check-in staff to interpreters to OB caseworkers to medical assistants.
Interpreters are the front line, are the trusted person for patients who don't speak English.
Often patients trust their medical assistants, sometimes as much or more than their provider.
It used to just be a one-on-one conversation between the provider and the patient, but really it's bigger than that now. It's a team effort. And so what Upstream did was just broaden our horizons immeasurably. So when the woman comes to the health center, everyone from the person who takes her phone call to make an appointment, who checks in with the front desk, the medical assistant who confirms and takes her information, the nurse who works with her, all of these people know about family planning and contraception.
And the ultimate goal is to be able to provide same-day access to any method that the woman feels is best for her.
I think that creating a combined sort of collective mission amongst all of our staff was what we needed to be able to sort of take it to another level.
I'll tell you that one surprise is that our staff received this training so positively, and we got superlative comments after the first training, like, this was the best thing that happened to me since nursing school.
The vast majority of women are good candidates for IUD and
It was awesome. I love it. The other day they came in, I just wanted to go back again.
There are new technologies available to help women take more control over their reproductive health. You have the IUD and the same horizontal frame. It requires some technical skill and some training to learn how to do. But it's really very readily trainable.
I was totally blown away by the fact that this was available to our health center for free.
When a woman comes in to see her provider now and she's interested in talking about the timing of her family, we can say to her, well, are you interested in having a child in the next year? And their answer is usually, absolutely not. And if they say that, we can say, we have great choices for you now. We get used to be able to say that.
Some of our teams are up to over 85% of eligible women are being asked that question. We're talking, even when a woman comes in for a sore throat, she's getting asked this question. It's incredible when you consider that it was zero before Upstream training.
Upstream just never says this program is going to fold. Upstream says this program is going to succeed. They came in saying, we anticipate we're going to encounter challenges in billing. They had billing and coding experts to work with our billing department. They help us by replenishing supplies that we need, or help by helping us figure out how we're going to get new supplies. We had some time teaching these providers how to do IUDs, but it just wasn't enough time. I said, well, we have some mannequins, and we have an expert. She'd like to come out to your health center and just spend some time. I was just amazed that they never seem to run out of energy for us.
They're brainstorming with us over challenges. They are working with us to make sure that we're maximizing revenue when we're using these methods. So they're definitely still present, helping us until we reach that goal of same-day access.
I had absolutely no idea of how involved they would become in the inner workings of our health center, how connected they would be to our staff, to our providers, and to the mission of the center, and how they would keep such a high energy level for their goals. They just went above and beyond. I would never have imagined it.
And we want to change the culture so that this is seen as primary care. This is seen as urgent care. Because in terms of people's lives and the impact that unintended pregnancy can have on people's lives, this could be life-changing for many people.
It puts the decisions around reproduction back in the hands of the woman. And community health centers, this is something that we always believe in. We believe in empowered patients who know about their health care. It's made us feel like, oh yes, that's why we work here.
Thank you. So for those of you who are on the phone, we will send out the presentation so you can watch the video. I realize you probably just had to listen to the video the whole time, so I apologize. So one thing that I take away from that video, I've seen in
show you how we created our amazing new website.
YouTube ads, sorry. One thing that I saw in that video that has come up in conversations with medical directors of clinics and clinicians is, you know, in my practice, we do a little bit of all of these things already. You know, like I personally am staying up to date on new guidelines and the options for IUDs and implants. The staff wants to do it. We have better reimbursement rates now from Medicaid in Washington State, so there's a lot of pieces that are in place and available. But they said it's not all kind of coming together for us cohesively, right, in terms of how our scheduling and our flow and our billing and our provider systems all work together to make contraception more easily accessible to the women that we serve. And I think you see that in the video. It's about really being intentional and working upstream, if you will, of the visit and making sure that systems are in place to make this easier. So here in Washington, we're at the beginning of our work. We're finishing up our project in Delaware this year and transitioning to Washington State, working in partnership with the State Department of Health and ACHs. Our intention is to work with enough clinics across the state to reach all of the women of reproductive age in Washington who need access to publicly funded birth control. So we've set that goal because Washington is a huge state. Obviously, every woman in Washington state should have access to the best forms of contraception. We need to start somewhere, so we really want to start where that need is greatest, which is women who typically have financial, logistical, transportation, and other barriers to access. And then our hope is that federally qualified health centers, Planned Parenthood, will be an example to the rest of the state, and that we will eventually achieve kind of spread across the state of Washington. So our intention is to begin training and technical assistance work with health centers next spring. So this year our goal is building relationships with all the ACHs, figuring out what our partnership looks like, and talking with health centers who are interested in working with us and laying the groundwork to make that possible starting next year. Our intention is to work with systems in kind of a cohort model so that we're working with about 10 health systems per year over the course of the next 5 years. And we do that for two reasons. Number one, so we can learn and adapt and iterate, and also so just we can be efficient with our resources and spend most of our resources on training and free birth control. If we try to do this all at once in 1 year, we would have to hire 2 or 3 times the number of staff. This timeline just talked through that. So again, 2018 is really about building relationships, getting the word out, lining up who those first 10 agencies will be that we work with, and then training and technical assistance would kick off next year. In terms of what typically indicates success with different health systems we've worked with, I think there's three really big categories. I think the first is surveying a population who is in need of better access to high quality contraception. So that's really the first question we ask is this a system that will benefit the most from their patients being able to have better access? The second is influential and engaged leadership. So is this something, many of you are going through practice transformation right now, and you know, your engagement and direction and leadership in that is one of the most important factors in success. Upstream's work is a quality improvement initiative as well, so it's the same concept that leadership needs to be engaged, people at the staff level need to be engaged, and it's something that the entire organization is committed to doing. And then the third is organizations that are committed to data-driven quality improvement. So we're very goal-oriented. I think we all know that's the best practice in practice transformation and quality improvement is setting goals and measuring success. So organizations that want to set goals for how many women are we going to talk to about pregnancy intention, who want to measure what method women are getting now, and then what method they have access to in 3 months or 6 months, so that we can work together to make sure that you're meeting your goals for improving access. Another important component of our work is we're putting together an advisory committee this year, a group of healthcare leaders across the state who can help us really refine the strategy of which organizations we should work with, which parts of the state are going to be most critical, and then also dealing with policy issues that potentially could help expand the scope of our work. Great example is the Take Charge program in Washington State. Everybody familiar with Take Charge? Free birth control, free family planning services for women who are not on Medicaid but are up to 250% of the poverty level. So not eligible for Medicaid but don't have private insurance. There's a gap in Take Charge though, that it's only available for people who are citizens. So we have a big gap in undocumented women across the state being able to access family planning services for free. If they're already pregnant, they'll get it for a year through maternity care, but we think that every woman in Washington State should have access. So there are some policy gaps still in the state that we may work on as part of our advisory committee as work as well to try to achieve some of those big kind of statewide scale solutions that are out of the scope of an individual clinic to try to solve. So ACHs are an incredibly important partner for Upstream in Washington State. It's an incredible, fortuitous, non-coincidence that we're trying to do this work at the same time around quality improvement and practice transformation. Our intention is to work really closely and in a really integrated way in all of the communities where we're working across the state. And I think that there's a few key things that you as an organization can do that would really help us to reach more clinics. I think, first of all, it's just continuing the conversation about integrating family planning and contraception in primary care. That's not a given in many parts of the healthcare system, so having that conversation, helping to make that a standard practice and assumption. Second, making the tactical choices that will really integrate that, such as using pregnancy intention screening as part of a health questionnaire and a health screening. And then finally, we would love to connect with health systems who you represent or you work with who would be interested in working with Upstream either next year in our first year of work in Washington State or in a couple years. So the time isn't always right for every organization to do something like this, and we acknowledge that. I was just meeting with a big FQHC in Seattle last week who's doing a lean top to bottom review this year. And they're like, we desperately want to do pregnancy intention screening. We really want to work with you. We are so up to our eyeballs in lean right now that we just, can we come back to this in a year, and then we really want to work with you. And that that's important to us as well, because organizations, as you know, need to be ready for change and for quality improvement to really do that. So that's the end of prepared presentation. Happy to answer any questions or if there's any comments or recommendations to share. Yeah.
If you have a chance, I would like to visit when we're done, so if you can hang out for a few minutes. But initially, what comes to mind is that I see the impact that it's creating in the traditional sort of health settings, particularly as it concerns the primary care. I'm very impressed. I wonder if you had any experiences so far working with behavioral health, or particularly women who are in the midst of mental health and addictive disorders.
Yes. Yes. Thank you for that question. So in our work in Delaware, we partnered with two kind of primary types of sites. One would be more traditional clinical settings, so the F2HCs, Planned Parenthood, hospital systems. But then we also worked with a variety of community services organizations who were working with women in crisis, who were working in the foster care system and providing wraparound services. So we trained many of those kind of community health worker, that's not what they call them in Delaware, but that type of role in those organizations about how to provide counseling to their clients and then make referrals to organizations that could provide them birth control. So it's a population that we've adapted our training materials to train community health workers and clinicians who are working in that environment. Does that answer your question?
Partially.
Okay.
So I don't want to hijack the session. That population that I'm speaking of is perhaps a full step or a step and a half deeper into the rabbit hole.
Mm-hmm. Mm-hmm.
So I'll give you a quick example. You know, I part of my teams in Yakima, we have a methadone clinic. So for us, our original intention, so this is when it comes to flexibility of the bilateral integration, it's a shift in thinking from all differences. So for us, we are not in the business of women's health, or we're not in the business of primary health, but when a woman is addicted to opioids and we're going to prescribe methadone or any other antagonistic, the fact that they might be pregnant or soon to become pregnant, then becomes an urgent factor for us.
Absolutely.
So that's what we have learned to address it, not because we're in the business. So we do, and you know, those are conversations, and I was listening to how you're phrasing questions, because I think we're asking good questions. They're not, you know, assaultive or denigrating or something more about intentions for women to become pregnant or becoming pregnant and so forth. But it all revolves around the use of the medication.
Yeah.
I mean, somebody methadone treatment, if they get pregnant and those are not addressed, guarantee a stillbirth.
That's right.
If they return to active using and then we're concerned because we know what can happen and so forth. Well, the same thing happens for persistent mental illness. So I'm always interested when I hear you guys present and activism, my thinking. I'm always interested in seeing how are we going to do it in this side.
Yeah.
Because part of the failure is me getting someone who's active using opioid, homeless, living under the bridge, coming in from methadone doses, to connect them to an alternative. But my mind is, can I replicate that here?
Yeah. Yeah. The women.
You don't have to answer because I know I give you a lot of junk to think.
Yeah.
But it's just an effort for myself to think bi-directional.
Yep.
Rarely we think this way of the street. So.
Yeah. I think that's probably something that's on a lot of people's minds too, because I know opioid treatment is a big component of the work of the ACH too. I think we should continue the conversation after this too. But the other thing I would say is just that the greatest improvement in unintended pregnancy rate occurs among women who go from using no method to any method. And then there's a less dramatic improvement in women who go from moderately effective methods to most effective methods. So some of the women, so in your specific instance, there's an issue of, can you get the women you're working with the best option for them that might be long-term, but how do you also help them in the short term, especially if you are not operating in a clinical setting and you have to refer them somewhere to get a more effective method, to get an implant or an IUD that requires a procedure. So those are the kind of specific questions that we
Correct, and we do that initial set of methods that you're talking about, and I like to be that we're successful on it. But then again, you mentioned when you were doing your presentation that because there's a human element in having to take a pill every night or having to use the condom every single time.
Right.
I think my expectations need to be retuned in thinking that this is someone who merely is managing the daily bread.
That's right, yeah.
You know, and then put on top of that the expectation that you have to take this pill every night, or, you know, you have to walk around town with a pack of condoms.
It's a lot to ask.
Yeah.
Yep, it's a lot to ask. So it's really about getting her something that will help in the long term, and how do you help her with contraception in the 2 days that it's going to take for her to get to the FQHC that can do the procedure, right? Yeah.
Thank you.
But your last point is exactly why LARP is such a primary focus on group from maternal health group, because it is that population that doesn't need much on their plate to manage and think about. So thank you for bringing that up. The other thing I wanted to point out when we talk about the pregnancy intention screening or the one key question is we're really talking about one answer that we're going to get from clients, right? Which is no, thank you. I'm not interested in being pregnant the next year. The other important concept of that pregnancy intention screening is you may get the yes, I'm thinking about it, or maybe I don't care. Maybe it doesn't matter. So we need to make sure to take that opportunity as well, which is why we're framing the question and saying, are you on birth control? No. But are you planning to get pregnant? Yes. That's where our chronic disease prevention group comes in. That's where the impact of some of the other commentaries will be helpful, because that gives you're working on that the opportunity to say, okay, are you taking, you know, receiving nutrition, especially in renal tube defects? Are you managing your weight? Should we have a healthy weight so that we aren't dealing with gestational diabetes and some of the other things for chronic conditions and chronic conditions? That's our unintended pregnancy rates that this process can benefit.
Great question.
Yeah.
I know, for time, but real quick, I'm just wondering if you have worked with emergency rooms at all. You know, many times, a lot of the patients that I yell talking about, the only care that they're receiving is in the ER, because they're really chaotic, and we've got to grapple when they're there. So have you, do you have experience in some sort of around, like, if we've got somebody in the ED, and they agree tonight, right now.
Yep.
Let's get that in. And so have you developed anything like that?
Yeah, in Delaware, we work more in urgent care, but in some emergency room settings. The challenge is typically an emergency room is attached to a large hospital system, and large hospital systems are, you know, so easy to get them to make big changes, right? Or they're not at all. So if we're able to work with large systems, yes, then that would absolutely be part of the conversation. With a large hospital system, it would be how are you providing contraception in primary care? How are you providing contraception immediately postpartum? And then how can we help you make this available in an urgent care or an emergency room situation?
We have time for one more question, so we can get to Brian. He has to take off at 11. Sue, did you have a question?
Just a quick question. How is Upstream funded?
Great question. So nationally, we're funded by family foundations who made grants to our national organization. In Washington State, we're also funded by Washington-based family foundations and individuals. We're not funded by industry or pharmaceutical companies at all. It's all philanthropy money.
Chelsea, thank you very much.
I'll be here through the end of the meeting and for a while too, if people want to talk. Thank you.
This is really exciting work. We actually kind of accidentally became involved with intentional pregnancy planning when we were reading through King County's project plan. Carol and I, when we were doing some of our right backs, actually looked at other project plans to see how they responded to some of the areas that we were responding to. And they happened to just bring this up, and I'd never heard of this before, so I did some research, and to me, it was like a no-brainer. So things have really worked out very, very well with this, and we're looking for opportunities for partnering with Upstream and collaborations with FQHCs, possibly hospitals, different settings, having this being part of the transformation of care that we're doing and integrating it across the spectrum of care. Up next, we have Dr. Brian Sandoval. Dr. Sandoval has 9 years of primary care experience in several practice settings. He's also the director of the Primary Care Behavioral Health Integrated Program at Yakima Valley Farm Workers. He's part of the GREE Collaborative. In respect to the Greater Columbia ACH, he was the co-chair for the bidirectional integrative project area. He comes with a lot of experience, and we're going to be doing a bit of a refresh today. He spoke last year when we did our project area rollouts, and he's going to give us an update.
Thanks, Wes. So thanks this morning. I know a lot of you had to travel too, so thanks for being here. I didn't call this bidirectional integration for a reason, because I feel like it's more than just bidirectional. There's a lot of directions we need to integrate. And so today I'm going to talk a little bit about basically what we kind of know from the 30,000 foot level at the healthcare authority. I'm going to introduce some research that, some findings that we came up with. One of the things that is, I think, a little bit unique about our health system is that we've done the primary care behavioral health model, which emphasizes a lot of the GREE collaborative elements, and we've also done collaborative care. So we've done both, and I think there's some key findings there to learn from and think about as we move forward into integration. So I'm going to be talking 30,000 foot. I'm going to share some data, and then hopefully we can draw some implications from this data so that we can actually think about how we want to move forward as an ACH and talk about some next steps. So I'll start with the toolkit, and I know that people have seen this, and I apologize for the small writing. I usually don't like to put that much text on slides, but I couldn't find another way to do it. So I think the really important piece here is what is underlined. What is underlined here is that we need to create an integrated system. And when we begin to think about an integrated system, it involves multiple levels, multiple people, multiple approaches. And I think that if we don't think about the system at the outset, we're going to miss something. So, and I think the other thing that's really important is to begin to think about the metrics, right? We've got system-wide metrics, we've got project-level metrics. Again, I apologize for the small text, but the idea that you really need to know here is that the takeaway is we need to begin to start with the end in mind. We need to be able to think about what these metrics mean to us, because this is ultimately sustainability for us. And this isn't necessarily, we don't just go straight to the end, and I'll talk a little bit about that. We need to think about, like, what are the steps to get us there and build an effective system so that we're able to sustain this long term. So in the area of behavioral health integration, there's really, the toolkit breaks down for us like what we can do, right? There's basically two kind of divisions of behavioral health integration. One of them being primary care based, right? So you've got integrating behavioral health into primary care, right? That's why they call it bidirectional. But I think it's more than that. We'll talk about it. So there's the GREE collaborative approach, which I'll talk a little bit about. And I'm also going to talk a little bit about collaborative care. So those are your primary care-based integration approaches. Then you've got your behavioral health system integration-focused approaches, which is what we call a behavioral health home, or integrating medical services into a behavioral health clinic. Or we have enhanced offsite collaboration, which is really working on improving the collaboration among systems. And I would say offsite collaboration isn't just about behavioral health systems and primary care systems collaborating. It's actually also about the systems that are out there, specialty services, the peer-based services, those kinds of things coming together to help out. So we'll talk a little bit about these in a bit, but I just wanted to kind of give you an idea about what that looks like. So if we kind of break it down, the green ones are primary care-based. The orange ones here are more of your behavioral health system or community-based, with the ACH in the middle. So that's bidirectional integration in a nutshell. I think the healthcare authority's intentions were more about kind of taking all of these things together and mishmashing them together. And what you notice here is I took the lines away from the circles because I do feel like we need to kind of mash them together a little bit more. And the other thing that I didn't do, because I probably wouldn't be able to read it, is I think that each one of these circles actually should be weighted differently as we begin to start looking at this. If we just kind of dump it all into these models and we call it good, we're going to really be missing the boat on figuring out how to transform the system. So I'll talk about that as well in a little bit. Okay, so this is my 3-year-old's favorite slide because he helped me build it one day because he likes construction stuff. The reason I put this slide together is because I want to begin to think about the system as a whole. And you notice here that you've got a building, you've got kind of this concept of higher levels of care. And at the ground level, not even at the building, you've got peer resources and you've got community-based resources. So before you can even get to the system, we have to think about how we can access people that aren't engaged. So that's one part. And so that's one of the things, and I won't be getting into that too much today, but I think I wanted to put it here so that people at least understood that part of what we do. But at the foundation, you'll see here is primary. And I put primary care in the foundation because it is the entry into the system that people access most frequently. So we have to think about that. And there's really kind of two approaches, kind of two bodies of, different approaches to the work, which don't have to be mutually exclusive. One of them being brief intervention and serving a large subset of the population and seeing all comers. And then you have a care management approach. What I wanted to talk a little bit about is people usually go into the building and go up and take the elevator. Okay? Most people do that in a tall building, but there are people who use the stairs. There's less people that use the stairs, right? But there's still people that use the stairs. Some people wear their Fitbits and that's what they want to do and they're motivated. Some people are super motivated to get to the higher levels of mental health care, behavioral health care. And that's awesome. We love that. But a majority of the people use the elevator. Majority of the people come in through the front doors of primary care. Okay? And so the reason that I see primary care as a foundation and having a strong primary care base is important is because if we don't do that, people aren't going to know which floor to tap on the elevator. They're not going to know how to navigate that building. So it's really important to help people understand, to treat people where we can treat them. Because notice the levels get smaller as you go up, right? There's less and less resource the more intensive of services you get. So we have to get good at primary care so that the other resources that are above it can be more effective with the population they serve best. So it's important to help people navigate the elevator. And we do that through better intervention, opening up intervention to a lot of people, and better care management. And so that makes the rest of the system function better. Now, these aren't models, right? This is the system. And I want to keep going back to the system because I feel like if we continue to talk about models, we're going to miss this point. So I said I was going to talk about models, so here's a slide about models. And here is, we basically took two different models of care and tried to see what we could do by putting them together in a stepped care manner. So we had a primary care behavioral health program, which started about 6 years ago. When I started with the organization, we really started to build the infrastructure around this program, which is basically the concept of seeing a large subset of people in a primary care setting, coming in, when patients come in, they meet with their medical provider, there's a warm handoff, they see the provider, the behavioral health provider, at the medical visit in the context in which they're receiving care, right? Immediate need met. They're part of the team, it normalizes it, reduces stigma, gets people engaged at the outset. That was the basis for our behavioral health integration. And I'm going to be sharing some data here about what we found and how many patients we've seen in a minute. But the idea is, the idea of behavioral health consultation is to make primary care work better. And if you go back to the last slide, that's why we integrated behavioral health, is because we need primary care to work well so that all the other systems can work effectively. So that's what it looks like. We also decided last year to do collaborative care. Now, this is, I have to credit Mark Avery at UWM. He's actually not there anymore. But he's the one that put this together. You can see the picture there is old because collaborative care is old. It's been around a long time, right? And the good part about it being old is that there's a lot of things that have been learned. The bad part about it being old is that it hasn't changed much. It actually hasn't changed all that much over time as we've changed and moved into more value-based care. And I'll talk a little bit about that when we get into the, when we start kind of matching things up. But I think a lot of people know what collaborative care is. I'm not going to get into the details, but what I wanted to give you guys an idea of is think about having a system where you treat all the comers, you see everybody that comes in the door, and a consultative model where you meet their needs as they come in, and then you add a collaborative care step as they need more services, right? As the intensity of the services increases, right? So you're actually, in our mind, thought we would step people up into a higher level of care in primary care as their needs increase, okay? And we thought conceptually, right, it makes sense, but it's not actually what we found. This is what I thought it was going to look like. Right? And this is an actual drawing. It's not actually a napkin, it's actually a piece of paper, but one day I was like, I think I've got this figured out. I know how this is going to work. And I sat down with my team and I was like, I just kind of went crazy with this pen. And I said, this is what it's going to look like. We're going to risk stratify. If you notice up in the right corner, there's the ED. We're going to figure out how to reduce ED utilization if we're bringing on collaborative care. We're going to do a bunch of really cool stuff. Boy, was I wrong, and I'll show you why. So the first thing is, let's go back to, before we get into why I was wrong, let's get into what we know from our current primary care behavioral health program. So last year, this is really recent data, 2017 data, we saw about 15,000 unique patients. That's a lot of people. And by the way, that's through 13 full-time staff last year. So think about that. 13 staff, 15,000 patients. That's a lot of people with not that many staff. The population penetration is 15%. Population penetration is an equation by which we see how many people come in the denominator, how many people come to the door of the clinic and see a primary care provider. The numerator being how many people have met with our behavioral health consultation team. It yields you a percentage. Basically, it's our footprint in the door. And it's actually a little bit higher. The data's skewed, but I wanted to be inclusive of all data, to be fully transparent. We had one clinic that just started in November, so that's why they have 4%. That kind of skewed our data a little bit. But if you actually take that clinic out, our population penetration range is anywhere from 11% to 24%. So you can imagine, too, 24%. 1 of every 4 to 5 people that comes in the door sees behavioral health. That's integrated. When I mean integrated, I mean routine. That is routine care. So we need to think about that as a true hallmark of integration. And so, and it's there in the data. This is what we're seeing. This didn't come out very well. It looks like a computer screen from 1984. This is hard to read. But the long story short here is you need to know we see about 10 patients a day. You saw the program adoption, population penetration. Our clinical measures, we see about 44, 50% improvement. That is actually equal to collaborative care. We have, if you look at some of the double the depression research out there, monotherapy, 19%, doubling the effectiveness is 40-something%. So it's better than antidepressants alone. And one of the things that we found, actually this was a couple years ago, was that for our top 100 utilizers, we were able to reduce their primary care visits by 2 visits per patient per year. So those are meaningful metrics. I think the PHQ-9 and GAD-7 are actually less meaningful metrics. And we'll kind of talk about that as we go along. But what is important here is the behavioral health is routine. It's a part of care, and it's a part of what we do is our service structure. We also do groups, because why not? Because we have the flexibility within our care model to do so. So we've branched off into population-based groups. We've got quality of life, that's a pain management group. We don't call it a pain management group, but it's a pain management group. We have experimented with different strategies around pain management, one in which we, the group with the highest attendees, guess what? Their opioid prescription gets filled at the end of that group, okay? Right? So a carrot helps, all right? It does. What we find, and I'll tell you this, we find that there's greater engagement when you don't do that, but there's greater numbers when you do that, right? Because there's a lot of people that don't want to be there, but then they get the opioid prescription, so they're there, right? It's a part of the care plan. It's part of the algorithmic structure and how we manage pain in certain clinics. But we do know that there are a lot of people, and we have some of the data that we are working on right now, that the people who come in, there's a lot of people that come in who didn't feel like they wanted this group, but actually, at the end of the day, thought it was actually a pretty good group. So it's engagement, right? We're working on a centering. Anybody heard of centering pregnancy?
Yes.
Awesome. So centering pregnancy is something we're working on at one of our clinics, which is really cool. It basically integrates behavioral health and follows the woman through the pregnancy cycle and then post-pregnancy. So, and then this group actually becomes a cohort that becomes their own support group following the pregnancy, which is really cool. And then we've recently got into diabetes care. And we actually, this is we don't have the data yet for this, we're working on it. The diabetes group is one which it's a group medical visit that's led by the medical provider, and our behavioral health consultant comes off and is a part of that group along with our dietitian. So, so this is what we're doing. This is very early stuff. The quality of life at the top, that first one's been around a little bit. The other ones we are just developing. So a couple months in, but there's some data for you. Okay, this is another one of those 1984 computer things at the top. Okay, so I'm going to talk a little bit about collaborative care. Checking my watch, see how much time I got. So I want to talk about this because I think this is really important. So remember we did primary care behavioral health, the CL Commerce model, and then we did collaborative care. And this is the data we got back. Now, I think that there's a couple of glaring things here. Number one, 100% of our patients. That's awesome. It's great. Couldn't believe it. But what we didn't do is meet all the other requirements. And, you know, that's actually our reimbursement was tied to those requirements. And the reason we didn't meet those requirements is because we didn't need to. And I think that stepping back from collaborative care for a second, we didn't need to do all those things to get the end result that we wanted. And the one challenge that I've seen with collaborative care is it's one dose. It can be one dose. This is what you're supposed to do. And that sometimes there's not as much flexibility as we need in primary care. So we got the remission. We did it. We didn't get as many people engaged as we wanted to, and I'll talk about that on the next slide. But we did it more efficiently. We found a way to do it. We didn't actually have to use the psychiatrist as much. We didn't need to contact them 2 or more contacts for 25% of our caseload. Because our patients told us they were better and they didn't need us. Actually, we had patients tell us stop calling us. We did. So we had to stop calling them. But what you want to think about too is when we start thinking about the G codes and collaborative care, those are tied to doing these things. You have to actually attest to doing collaborative care as designed by this. What I'm saying to you is the tenets work. The dose in which they work may not be the most efficient dose. So that's why I'm trying to open everybody's eyes to think about this a little more globally, okay? Because it can work, but it's also not the panacea, all right? So this is what we thought when we first started this step care approach. We thought that we would do some screening, it would go to the PCP, they would handle what they could handle, then give it up to our primary care consultation group, then a subset of that group would go to collaborative care, and for those people that needed a higher level of care, they would go to specialty care. Makes sense, right? That's not how it happened. We got people, our primary care saw the people, got them, and actually, so the amount of people that primary care took on increased. The amount of people our primary care behavioral health consultation service increased. But we had a lot of people that scored 9 on the PHQ-9. So they didn't graduate into the collaborative care model, right? So our caseload that was supposed to be 50 ended up being like 35. Okay, 40, I think we ended up 40. And it's expensive to manage those 40 people. If you think about how much it costs, and you guys can look into your own contracts, but those are expensive patients to manage. So what we found is that they didn't get into collaborative care as much. We managed them with our primary care behavioral health program. We didn't need to contact them as much, and we couldn't, frankly, because they didn't get into the collaborative care arm, or we were getting them into our primary care behavioral health arm and didn't have the capacity to do that. But in reality, we still achieved your mission. So the end game worked. We just had to adapt. And I think that there's going to be the clear message here is we need to think about the approach versus the model. We need to think about what the end game is. We need to think about what's important and adjust our approach to that instead of putting us in these boxes of models. So this is a clear example of why we need to do that. So what can we learn from this? I'll try to land the plane here and see. I think the first thing is I don't have the answers. If I did, then I'd probably be flying on a private jet somewhere. I don't know, because there's got to be somebody that knows all. That's probably really well. So here's the deal. Everybody seen the Christmas tree? Yes? Okay. Christmas tree. All right. So these are the measures we're responsible for. Okay? These are the problem statements that we need to think about addressing. These aren't the end problem statements. I mean, these are the end problem statements, but there's intermediary problem statements we need to understand to solve these problem statements. Okay? The first problem thing that we need to understand is, what are the capacities of the models that we have to actually solve these problems? And the idea is not how well can we take these models or how do we expand these models to include this, it's should we. Should we expand these models in these areas? So the first question we need to ask is, should we? And we'll look at it as we go along, because ultimately, at Greater Columbia ACH, we've got 250,000 people we got to figure out how to take care of. And if we burn resources in the wrong way, we're going to be in a bad place. And if we continue doing the things we're doing and just expanding it a little more, we're not going to meet that. We're not going to serve that 250,000 people well, behavioral health-wise. Okay? So if you think about this, even if we conservatively say 20% of these people, 50,000 people need behavioral health care. That's a lot of people. And it's actually way more than that when we get into it.
Is that including youth?
Huh?
Is that including youth?
Including what?
Youth.
Youth, this is, I'm pretty sure all projections. I actually set this off the greatest. All ages. All ages.
That's all Medicare categories.
Yep. Medicaid, yeah. Okay, so let me go back here. So we got that, right? It's in everybody's head. So we've got these ideas around, well, how are we going to meet the Christmas tree metrics, right? How are we going to do that? I think the first thing we need to know is what contributes to the end game of the Christmas tree metrics. I want to start with ED utilization. Okay, so let's take a look at this. Is real data from, this is actually last year. Don't have the most current data, but it still gives you the idea about ED utilization. Here's the takeaway here. If we solely focus on mental health problems that present in the ED, we're missing the point. Because mental health is 1/6 of the ED business. Okay? Mental health diagnoses, that is. Right? So, and here's the other kicker. How many people are doing collaborative care? So what? And most people are doing collaborative care for depression. Most people are. There's other people that are doing it for other things, but most people are doing it for depression. There's another truth. Depression isn't a driver for ED utilization. In fact, there's some other data, and I won't go into it. Our ED utilization for depressed patients in our collaborative care versus our non-depressed patients was exactly the same. Depression does not drive ED utilization. What drives ED utilization is usually physical manifestations of anxiety, right? Or physical problems that people don't actually identify as mental health problems that come into the ED. So if we put all our eggs in collaborative care for managing depression, we're not going to solve the ED problem. I just want to be blunt about that. I know that isn't, some people don't want to hear that, but it's the reality. It's what our data tells us. So we need to figure out how to solve all these problems, and we need to figure out how to engage those people in a meaningful way throughout the system, right? And I don't have the answer. We are working on this right now. We are working with the ED. We're working with the physicians in the ED. We're working on pre-manage and helping us figure out workflows. We're trying all that stuff locally, because anytime any of these people come in the doors, we want to be on it. Because I'm going to tell you what, we weren't on it. We took the top 29 people that come in, and we figured out, I did chart reviews, because I didn't have a life this one day. I decided to do chart reviews. And we found out, not always in the problem list, we looked through the charts, 86% of those people that came in for the physical health diagnosis had a behavioral health comorbidity. It just wasn't on the problem list, and actually didn't go through their ED diagnosis. 86%. So if we're not, so I should step back a little bit. There's two categorizations of why people use the ED, two main categorizations. One is urgent care stuff, okay? People that use the ED like urgent care, okay? There's another subset of people, so that's a bigger piece of the pie, but they use it not quite as much. Then there's a small subset of people that use the ED very, very, very often. That's these people, okay? So solving the ED problem too isn't actually solving behavioral health. It's actually, that's only a portion of solving the ED problem. But we do know this. We do know that those people that use the ED a lot, 86% of them have some underlying behavioral health or substance use disorder. So that's important. Here's the other key factor here. We missed half of those people. Even though we saw 25% of the people that came in the clinic sometimes, we still miss those people. So we need to do a better job of figuring out when those people come in. So, yeah, that's stuff we can improve on. And I'm being very transparent with the data here because I want everybody to be a call to action for everybody. So, I want to make sure we're winding down here, but I want to make sure to talk about this too. And I'm going back to collaborative care because if you think about how many people we need to serve and the caseload requirements, we're not going to get there. And I threw this in there for people to understand what that means. And the other thing that's really important on here is not ED utilization. It's not what it's designed to do. Okay, BRIE Collaborative, then I'm going to land the plane here. So the BRIE Collaborative was a group that came in under the Healthcare Authority it's actually not under the actual Healthcare Authority, but the idea is through the foundation, the state foundation, to come together, get a lot of subject matter experts in the room and try to figure out a way to synthesize behavioral health integration. We got together last summer. It was a lot of trips to Seattle, which is great. Basically what we did is we agreed upon a variety of elements that are important in integration for behavioral health. Elements, not models. And this is what's important about the BRIE Collaborative. The BRIE Collaborative is not a model. It is a variety of elements that come together to form really good behavioral health integration. Now, there are elements of collaborative care, there are elements of the consultation model, and then there's other additional elements around team working within the context of a primary care team or a team in a behavioral health setting. So the idea, what we came away with was this concept of the co-location, being on site, collaborating, the degree and quality of the relationship, and the level of routineness and integration are three really important components. Those three drive the other components, which are routine access, shared care plan, screening, identification, follow-up. You can read the rest. But I encourage you to look at the full report because it will help you walk through what the elements are in the approach. So here we go. This is where we kind of land the plane. So if we really look at collaborative care, and this is just my opinion, and I'm open to discussion about this, I think it solves a couple things. I think the BRIE elements solve a few things. I think outside collaboration solves a few things. And on-site collaboration, working with people with really chronic disease and mental health. And I think off-site collaboration. And off-site collaboration actually should have a lot more check marks. I just probably need to update that. But here's the thing. These are still models, and we want to get away from models. So we need to think about the problems we're trying to solve right now. Okay? And that goes back to the Christmas tree and the intermediary problems before we get to the Christmas tree. So the intermediary problem, the ED utilization, is understanding what actually drives ED utilization, right? And intervening there. If we just focus on ED utilization, we're going to miss the point. We actually have to focus on the tenets of ED utilization. We're working on that internally. We're figuring that out. We've got a variety of different ways we're trying to work on. We've got kind of two separate strategies. One, we're working on the urgent care strategy. We have the other strategy around the behavioral health high utilizers. We're working on that based upon the data that we know that contributes to ED utilization. We're not just throwing things at the wall, right? And we're iterating. Build, measure, learn. Build, measure. If it's not working, iterate, learn. So I'm not a big fan of PDSA because I think people get stuck in the P way too long. But anyway, takeaway point number 2. Ask, should it be built, before we ask how it will be built. Should we expand certain elements? Should we expand models? My stance on this is we shouldn't expand models as much as thinking about the system approach and organizing our efforts that way. This is a really important one. Our approach, and these are again my opinions, and I'm free to debate them. And our approach shouldn't be dictated by TA. Okay, so our approach should dictate what kind of learning support we need. Not this training's available, so we're going to all go and then we're going to integrate it. Right? That drives me nuts. I just have to say it. Because I feel like we go into training about behavioral health integration without understanding the end in mind. Because it's available. But it doesn't, we look back at the check marks, remember where you're putting your eggs. That may not be the basket you're actually driving towards. So your approach and your understanding of what you need to solve by knowing the problem first should dictate the training you need to get there. Not, there's this training, so we're going to go and then we're going to find a way to generalize. We tried to make collaborative care something it wasn't. It wasn't that. Lastly, the components in the approach are greater than the model. The ideas of collaborative care are good, but we can get there more effectively. We can do it. We did. So the components in the approach of the idea should outweigh the structure of the model. So we need to be efficient. We need to make this thing work before we run out of money, right? Okay, so here's the next steps. So this used to be called the Strategic Planning Group. Now I just had to update my Practice Transformation Work Group to begin. We're going to be working on trying to figure out how all, and here's the thing, this is only non-directional information. We're trying to all work together. So that's the idea around the Strategic Planning Work Group, okay? Excuse me, Practice Transformation Work Group, which is to try to figure out how all this marries together on the curriculum. We're trying to, I think one of the big pieces, and I'm going to challenge us to do this, is what are the causal factors to those actual endpoints in the Christmas tree? How do we build the system to get there? How do we pay for infrastructure and reporting before we actually get to the metric? We have to do that first. Then we have to begin to think about how we interface with the coalitions that already exist to make it work and happen. And then lastly, the recommendations that come up with will go to the board. And so I'm co-chairing that and with Mark Kai, and really excited we get in this situation? Right? Not good. Not good. Right? So let's bring some sandpaper and make it work, right? Let's shave it down to be a round peg. All right? All right. Questions, comments, thoughts? Yes.
Thank you so much for the work. I'm really inspired. One point and a question.
Yeah.
The point is, I was captivated by what you said. If we can really understand the problems,
Yeah.
we can create more intentional interventions.
Yeah.
I'm hoping that maybe shifts the outcome metrics.
Yeah.
The outcome metrics were imposed into the problem.
Yeah.
Right? They were superposed into the problem without any pre-work. Okay, if you check this box and then you did a good job, it's part of what the outcome for the individual. That's not how science works.
Yeah.
So, okay, thank you for hearing that. The point that I was asking when, in your kind of graph, they have some steps, when you said we stop at BCBH and it's in yellow.
Yeah.
I wonder if you track interventions that took place there?
Yeah, so the
And ameliorating the behavioral health concerns?
Yeah, so PCBH is the primary care behavioral health consultation model. That is a brief intervention model. All of the interventions that are used there are empirically based interventions based upon what's coming in. Acceptance and commitment therapy, which is very well accepted and researched in primary care as a brief treatment. We use that to help us engage patients, get them to self-manage their conditions, so that way we know who responds to that level, and then we can refer them up from there. But it helps us treat a large subset of the population and focuses on self-management. And the clinical paradigm we use is focused on commitment therapy.
Thank you.
Yep. Other? Yes.
Early on in your presentation, you had information about efficiency or productivity.
Yep.
I wasn't sure who you were measuring at that time. Were you measuring the primary care provider or the behavioral health?
Behavioral health person.
Okay.
So we see about 10 patients a day. We also know that about there's a couple of parameters I didn't want to overbear everybody, but we actually have a dashboard that we look at to make sure that we're adhering to the principles of patient health. One of them is productivity.
Right.
The other one is population penetration, which I did share.
Right.
The other one that we use is model adherence. Model adherence is once our behavioral health consultant sees someone 4 times less in a quarter. We use a quarter as an episode of care. The reason, and we want that to be true for 90% of the people that we see. Why? Because first and foremost, we want to make sure that we're seeing a much more unique patient and not seeing the same 10 patients over and over. The other reason is 90%, because it's the 10% of people that will never go to a specialty mental health or something, because they just don't want to go and have that experience. We would love for them to go, but we need to set aside a chunk of our service to dedicate to those people.
And are you able to share that dashboard?
Yeah, I think I've got another presentation. I can share it with Leslie.
This will go on the website, right?
Sure, I can do that, but the point is we're looking at that. So here's the other thing, and I won't get carried away here, but let's say you have someone who's producing high, you're adhering to the model, but their penetration is low. You know what that means? We need to hire somebody else. Right. So we understand their staffing as well, right? And we also know if we've got somebody who's really productive and their penetration rate is low and they're not really doing the model, so we have to work the model in here. It gives us an idea around what the intervention is to help our program move forward.
So now I have another question.
Yeah.
So, obviously when you're treating for depression, you're using the PHP-9 or the A or geriatric screen. And are you using other screens for anxiety, PTSD, et cetera?
So, yeah, so great question. So first and foremost, we don't give the PHP-9 alone for most clinics. There's a couple clinics that don't have behavioral health folks. They're still kind of doing that with. We give the PHP-9 and the guidelines together. We actually have a 4-question functional measure that we're using too, which we're adapting. Here's the reason why we give the PHP-9 and the guidelines together. Because it informs treatment much more than PHP-9.
Right.
And we know psychopharmacologically, if there's a comorbid anxiety and depression component, that's a completely different. And it also helps us be more efficient in this. That's 9 questions.
Yeah.
If I got 7, that's 7 less questions I have to ask. Yep. Other questions?
Thank you.
Thank you, guys.
So, Brian, why don't you just stay here, and I'm gonna try to facilitate the discussion. I think I'll just jump to my second set of questions. The first question is, this is modeled what we did last month, is basically in one sentence, what would you say about Ryan's presentation? But I asked myself that question. I think I couldn't answer that. That's you distilled maybe your professional life's history here in 50 slides. And so I'm trying to think, boy, I don't know if I could really get that down to 1 slide. But I would like to go to the second set of questions and ask those of you, and Brian, you can jump in here. Those of you who are providers or work with providers, what do you see as the biggest challenge in your own organization to what Brian has presented on the basis of his work in Yakima or elsewhere? Any thoughts? What you saw from Brian, what would be challenges in your organizations to implement?
Yeah. So, we've been working on developing the bidirectional integration around the collective care model. So which is itself is a challenge, right? And now I hear Brian talking about really it needs to be much more an expanded concept. And so I think that will be a challenge, and I'm not sure if the challenge will take on this week.
And so how would it be a challenge? Would it just be resource-based or just training?
It'd be a challenge because it's a change in thinking, first of all. The collective care model, how I understand it, is very narrow and focused. And what I hear Brian talking about is the principles around breed are much broader and much more inclusive. So that is it, first of all, it's a change in thinking.
Right.
And then resources, and then all the other things that go with it.
Okay. So just a change of thinking, perhaps resources. Wes?
So I'm not a provider, but I'm interested in your ED data. So I've looked at for quite a while. We were looking at more than 8 visits. Obviously, those are individuals who are going to be repetitive from year to year. How do we, and if 90% of those are attributed to some sort of behavioral health issue, substance abuse, mental health, my question is how do we get it? And in particular individuals that have substance abuse disorder, as far as I know a person, she's a friend, a casual friend, who takes about 20 to 25 hydrocodone a day, and denies that she has a problem, attributes it to pain, and doesn't really need for treatment. And I'm sure that case is not alone. So how do we get a recognition on that individual's part that they need to change their behavior, probably go on to math and buprenorphine, and get into the model? How do we get patients into the system?
So first and foremost, a lot of patients are actually already in the system. That's what we do know. In fact, a lot of those people come into our clinic. Right? So there's a good, first of all, we need to focus on the people that we're already in the system and do a way better job with that and iterate. So we need to understand the people that we can already access and what works to change those people. And then we can work on generalizing that approach for the more challenging people that are outside the system. So for us, there is a lot of, the reason I mentioned acceptance and commitment therapy is because it focuses on values. What people tend to realize is they get focused on the treatment instead of the actual outcome in the life they want to live. And so we have to begin to change their thinking around, is this actually getting them closer to the life they want to live, the life that they've desired? And those are conversations that sometimes can, in the right setting, perspective is everything, Les. And so the idea is to make sure that you capitalize on situations to change people's perspectives and doing it in a way that's engaging. And the way you do it in a way that's engaging is making a normal part of what primary care already delivers. So these people already come into our clinics. We just have to make sure that they don't feel stigmatized and that it's a routine part of their care visit. And we do that for 20 to 25% of our patients that come in. That's pretty good. So we're trying to continue to expand that. And then from those lessons learned, we begin to think about outreach interventions Those are the peer, I mean, there's always those people that are dinging us, right, that are assigned but not engaged, right? I'm sure we don't have any of those people here, right, that have experienced that, right? So we also have to think about how to engage those folks. And I think that is a larger intervention around community-based stuff.
As a follow-up to that, so you see motivational interviewing as the biggest component to engagement?
I think it's one component. I think I'm gonna offend some people, but I think motivational interviewing is part of the issue. Motivational interviewing, I think, stops at the desire to change and action planning. And I think we need to take it a step further to actually engage people's values. That's where we pair motivational interviewing with acceptance and commitment therapy. So motivational interviewing is a pre-treatment to engagement, and acceptance and commitment therapy helps to bring in the values to solidify commitment. So if you really kind of look at that, go ahead.
In clinical practice, I love it, motivational training. Your question was, what inspired me to think is, what you actually inspired me today to think about is more systemic approach. In my humble perception, it is a heavy load to demand that the ER itself provides me all the data that I need. I mean, the person can have depression, addiction, poverty, a gazillion things. The ER, by definition, is concerned with a bleeding ulcer. So to think, he was talking about the casual or the causation. Well, the causation is a compounded effect. It's not a singularity. But it is a heavy duty to tell the ER, you need to give me data and why you're not addressing mental health and why you're not addressing addiction. And you should be calling an interventionist, and you should be calling a mental health behavioral people, and you should be doing this. Well, it's not the nature of ER. ER is, what is the presenting problem that might cause you death? Well, you're bleeding ulcer. Okay, we're going to tackle that. What do we need to do for that? Okay, 6 hours later, we have stopped the bleeding ulcer. You're going home. The next line is, we need you to follow up the bleeding ulcer. The referral to that is to a primary physician or to a specialist, a gastroenterologist, something like that. That is the design of ER. And sometimes I think that we are aiming wrong, and we're putting a shotgun in the wrong direction, and then getting upset because we're not getting the response that we want. Rather, interventions can be provided in the natural settings where people appear. Those are settings that each domain can have a greater level of control when we're trying to understand what factors move clients in those domains. And I think it's not too poetic of me, but I think that if I do those interventions correctly, as a result of that, I will see the decrease of ER. So it's a very hard metric to follow when I'm trying to tell the ER to explain to me why. Yeah. Well, why you was bleeding, man? You know, and stuff is bleeding.
Part of the work of the strategic, well, the transformation work, find those intermediary cost factors, right? Think about that. Going back to your point, I'll get to your question real quick, but going back to your point, the other thing I think about is mental health first aid is another thing that is starting to pick up more and more, and that's kind of that community-based engagement about the people that are unengaged. So it's making sure that we're destigmatizing mental health as best we can through mental health first aid, recognizing it, getting people motivated to engage. I think that that's one thing that's another big part of this. And then operationalizing more effectively the community-based services we already have and connecting those better. So those are a couple interventions around what we need to do, I believe, for the unengaged people.
Ronnie?
Okay, so I'm just trying to absorb all the information and just listening and things. The component that I'm not hearing is the support component. And coming from a place where I've been, boots on the ground, homelessness, consumers, low income, and just giving them the support to get them into services and navigating through systems. A lot of times they give up before they even come through the door, or they've been through the door so many times that they already know what their outcome is going to be. So they go in for that Band-Aid and they're out. Some of the things that I was able to accomplish during the time that I was there, and I didn't just volunteer for 5 years, no paycheck. So they come into my vehicle, that was the office, and they fill out everything that they had to fill out. And they would go go into dynamics of frustration and anger, and a lot of these people had co-occurrence, which is mental health and addiction. And that was my main goal, is to get them into services, keep them into services, and guide them through the services in the, as a support for them. And the outcomes were greater and more beneficial. But I went through the support systems with them as well. So if you're not going to have that piece, the reason why I really like Lutheran is because they do the wraparound services. They give those support necessary.
So
But if those aren't available in the hospitals or at the ED or for the primary care, those services that are being provided are going to still continue to be overutilized. I have one client from back when I was doing that is clean and sober, got a wonderful story, but she's clean and sober, she's proud of where she's at, and she attributes to the support that she receives, not only from myself, but from the agencies and organizations that she was able to align with and get that other support that she needed during her process. And not giving up.
So I think there's a couple of things we need to think about, and that is, again, operationalizing the resources that are out there and putting more resources in there. I think we get caught in this community health worker thing, and I think at the end of the day, I don't care what you call them, if there's people on the ground like yourself helping people, and that is a part of what we do, we need to make sure and bring them into the system, right? So I think that's the first thing. I think the second part is, in primary care, we started to recognize social determinants of health and been more intentional about that. And we're actually in one clinic that's very, very intentional about that. We're using that as kind of our incubator to understand organizationally where to go. We give out food. We have our internal food pantry. In our diabetes class, one of the reasons it's picking up steam is because we give out a bag of food at that. So we are starting to think about how to engage folks like that by starting to actually bring in some other reasons. They're all donations. We partner with the food pantry, we bring in our own food, we have donations, so it's taking what we know and making it available in every setting we can think of.
And food is, I did a mobile food as well. Out there because food is the dynamic that keeps us moving forward. We all need to eat.
Well, you can't.
But there's also conversations when you're eating together, having a conversation. With health and welfare as yourself, as a person, and you're giving that element of humanization. It's that one-on-one piece. It changes things. And if they're not feeling that when they walk in the door, they're not coming back.
Well, part of the reason we constructed the groups is for peer support outside of the clinic. So the relationships usually, especially with the parenting groups, those are usually high risk. Those continue outside the group. So I appreciate you sharing that, but I think that's a good point, and that's part of the reason we started these group interventions and we started together, kind of internalizing social determinants.
Okay, before I move from this topic on to the next one, stay here, Brian, if you would. Any other further comments about you folks who actually deal with patients and the challenges you see with what Brian presented?
I have just one comment that I think I would hate for us to lose sight of, and that is that this really needs to be done community-based.
Yes.
Primary, your patient is your patient, but what you don't know is they're also at neighborhood health, and there's these other small clinics, and we all think that they're your patient, when really they're the community patient. So in order to be effective, we really need to make sure that somehow that this is community-based, because we share in those patients, they move among us. And in order to really share resources, that's really the key.
What if the coalition, so I really appreciate you saying that. What is part of the, these are already doing on our statistic characteristics and stuff, but what if there's part of the coalition's responsibility at the local level is to bring together a clinical needs-based kind of meeting where people start to talk about cross-patient. I don't know. I don't have the answer.
That's what we're doing.
Right. But how do we expand that? How do we think about it? So I appreciate that point. I think, again, I don't have have the answer, but I appreciate that perspective. And that's part of the reason when I did the building, there was stuff on the, because there's people that don't get to the clinic, right?
Right.
So, yeah.
Lots of.
Yeah, tons of them, right? Those are our unassigned, our unengaged patients that are assigned but not engaged.
Right.
Yeah, tons of them.
And that's really my last question on this section is, those of you who are community-based organizations, how do you see this sort of fitting in with the slides that Brian put up, which really, except for maybe that very bottom area of your first slide, didn't really show too many CBOs. So anybody want to take a crack at that? Because this is our model in the ACH, is that it's not just clinical provision of care, it's the environment, and just like Becky was saying. So any other CBO here want to take a crack at that? No? All right. So
There's one more thing I just want to say is I think I just want to call out what it is. There's really not as much technical assistance as there needs to be. Let's just be honest about that. So we really need to learn from each other. And I think part of that too is for those people that are doing this and that are willing to help others out, this is where the collective effort comes in. And so, not volunteering right away, but, if there's, we're willing to work and help. I think we all need to do that. So.
all right. I think I'm just gonna break right here unless people are dying to ask Brian more questions. You look a little fatigued this morning, and we've lost lots of people. So, any last minute questions of what Brian has laid out, which is really quite something, and will be on the website soon, I assume.
Thank you for your work.
Yeah, that was very illuminating for, I think, a lot of us. So thank you, Brian.
No problem.
Carol, I mean, is it not true that bidirectional integration of care is the largest chunk of dollars that has been allocated to all the ACHs across the state? So just to reiterate, there's a lot at stake here, and undoubtedly we're going to come back and revisit this issue. And Brian, hopefully with your work on what are we calling that committee now?
Practice Transformation.
Practice Transformation Group. We'll hear from you again because that was a lot to digest. So thank you so much. Last words from our executive director.
I think we've got a really big shoe planned for you next month too, so come back.
Next month, we hope to focus on the second required project area, which is opioid use. And so we hope to have Becky and Everett both come up and present around that. So we may tie in some additional presentations to that as well. So please stay tuned and come back and see us.
All right. Thanks for coming. Have a fantastic day.
That's the Irish